Thank you all for joining us today, and thank all the panelists for coming with us. This is all about human performance in a variety of formats. When Jan and I first started in this panel, we were interested in connecting us to human performance in potentially interesting environments. We thought first of Houston sports teams, professional sports teams, because the Rockets and the Astros are very famous for using data analytics in their competitive environments and as part of their personnel and amplifying human performance. So we were very excited about getting them to come join us. Turns out we picked the 1 month a year where every Houston sports team was busy and not available. So the Astros are obviously a little tied up. But then we actually stretched this into some more interesting directions and broadening that into the discussion of human performance as it relates to human health in the context of rehabilitation in human health, mental health, and other variety of things. And we were able to actually bring together a very interesting panel to have this discussion. So we're going to give each of the panel members about 5 minutes to kind of talk about their area of work. In keeping with Jan's philosophy, I'm not going to spend a lot of time on introductions, but I'll start with Dr. John Dewitt, who works for KBRwyle at Johnson Space Center.
My name's John Dewitt. I work at Johnson Space Center, and my area is crew health and performance. So my daily job, I basically am doing 2 things right now. One of those things is working with what's called the Systems Maturation Team, and that's NASA jargon for we're working on planning how we're going to go to Mars and how we're going to go to the moon. Or every time that the president or vice president makes a speech, where we're going to go to next, because we find out after they tell us. But in any case, we're not going to be able to do the same things we're doing now. We're going to have to spend a lot of time thinking about what are we going to take on these missions. We don't have, we're not going to take a space station of 10,000 square foot of space. We're going to take something much smaller. How are we going to keep the crew healthy? How are we going to make sure that they stay alive in terms of both being happy, not getting sick, not going stir crazy inside a small vehicle, those sort of things. So half of my time is working in that area. The other half is working on the actual exploration exercise device that we're going to be used. So my area of expertise is biomechanics, specifically when it comes to exercise. And what I'll do now, what I am right now, is the project scientist for the exercise device that's going to go into the exploration vehicle. So we're building those now because we want to have time to test those up on a space station and then send them to the gateway that'll go around the moon and eventually the transport vehicle wherever we send that, moon or Mars, probably moon first and then Mars. And then I have a second life where I work in the sports area. So I've been working with the Houston Dynamo in the Houston Dynamo Academy since the beginning of their academy in 2007. So I'm not with them this year, but this is the first year that I'm not with them. I also have coached at a very high level soccer-wise. I was a college soccer coach at the University of New Mexico before I came here. Currently, I am the assistant coach for the Afghanistan women's national team, and I was an assistant coach for the Trinidad and Tobago women's national team. So my area there was fitness and performance, but then the combination is being able to use data to help inform those sort of things. So the third thing I do that's a bit of a hybrid is actually work with some of the organizations. So I've done some work with the Astros, some work with the Rockets, helping them to look at their data and figure out ways that they can use it to help improve and inform health performance. So that's my background. Thanks.
Thank you.
So our next speaker will be Dr. Gerard Francisco. He is the Chief Medical Officer at TIRR.
Thank you very much. TIRR is the Institute for Rehabilitation and Research, a few blocks down the road. I'm also chair and professor of physical medicine and rehabilitation at UT Health, just a couple of blocks from here. I'm so glad that you invited me. It's sort of ironic because one of the reasons I became a doctor, a medical doctor, is that I hate numbers. That's why I did not do physics, chemistry, whatever. But I realized that numbers are very important, and it's something that I realized quite recently, primarily through research, through my collaborations with Marci O'Malley from Rice, and with other engineering schools such as U of H. It made me realize the importance of number, not so much as to measure, but to predict and possibly to help us manage our patients. So this was a really, truly an eye-opener for me. So this is our research building. It's a building from the 1950s. It's been refurbished, and the third floor is occupied by the Neuro Recovery Research Center, which I direct. We have an open floor plan, and this was done on purpose because I would like to force all the investigators to talk to each other, collaborate, because I see intersections in the many things that they do. So in this small space, we put quite a few centers and labs. We have the Center for Wearable Exoskeletons, Rehab Robotics, and Marci O'Malley is the director at TIRR for Rehab Robotics. We have a neuromodulation lab, a motor recovery lab, a neurorehabilitation lab primarily doing work on spasticity, Neuroengineering Laboratory, and human-machine interfaces that is under the direction of Pepe Contreras Vidal from University of Houston. So we have created this collaboration and synergies primarily to do this, is to help our patients, but in order for us to do that, we have to better understand what's going on with our patients. So in rehab, we are trained to observe. That's number one step in physical examination, is to use your senses without even touching the patient. So when we examine someone's gait, usually it's observational gait analysis. Even though there are gait labs, instrumented analysis that's available now, we tend to just do the clinical observation. The practical reason being it's quite expensive to purchase and maintain a gait laboratory. I think that's the ideal scenario, but in reality, unless we will be funded on an ongoing basis to support this laboratory, we will not be able to rely on this for all our patients. Secondly, not all patients that we treat, especially at TIRR, where we treat the most catastrophically injured and the most neurologically disabled, many of them will not be able to perform the tasks required of instrumented gait analysis. Now, we do have the capability now to use some to help assess some of the problems that our patients have. I think there's a more and more understanding of the role of EEG in understanding how the brain responds to a particular treatment. One of the studies that Marci and I and Pepe are collaborating on, or just finished collaborating on, is a brain-robot interface using Marci's robot and Pepe's neural interface protocol to understand how people with stroke respond when they are being trained in the upper limb using a robot. Right now, we tend to teach people the same way, but in reality, they respond differently. So we're hoping that we can have a better understanding of that and perhaps in the future develop protocols that can be applied to a wider stroke population. Physical medicine and rehab, we're formerly trained in EMG, but usually it's diagnostic, which is to find out, does someone have a carpal tunnel syndrome, does someone have a nerve entrapment, or a problem in the nerve root in cases of sciatica and low back pain. But this is a very underutilized device. Many of the rehab clinics have one or two machines, but it's usually used for the purpose of just making a diagnosis to rule out a muscle or nerve problem. We haven't reached a point that we are routinely using this to assess our patients with different conditions such as paralysis, muscle spasticity, which I think can be helped by information that we can get from the ultrasound. Many sports rehab facilities have the Cybex isometric testing, so it's used on and off. I know that they're using it now primarily to show insurance companies that they have made the difference so that they will be almost guaranteed payment. It's not really using that information to help figure out what is going to be the best way to treat someone with a knee problem or a foot problem. Of course, we have MRI, but right now our MRIs are just used to diagnose where is the stroke, where is the spinal injury, where was the brain injury, without really looking at further details that, we could. We just were never trained how to do so. We don't talk about the volume of the stroke lesion or the location of the stroke lesion or the interconnection between the different lesions and how it may affect the conditions that we're seeing and how it may have an impact on the treatment decisions that we're going to make. You see, in rehab, as I mentioned earlier, we're trained to really observe primarily. Even when we do research, most of the research in rehabilitation to date are observational studies. We have randomized controlled trials, but we are not trained to look at big numbers. In fact, I'm sure many of my colleagues are just like me. We are intimidated by big numbers. So I think in rehabilitation, in order for us to be able to take advantage of this, there has to be a grassroots effort in educating rehabilitation professionals as to what big data analytics can do for our patients. This is not just looking at an outcome measure, but perhaps even predicting responses to the different treatments. So phenotyping, for instance, a lot of exciting research by my colleagues are being done in Pittsburgh and other parts of the country, phenotyping outcomes of traumatic brain injury, for instance. So far, at least in animals, women do better than men after a brain injury. And I think it's because, number one, the brain is smarter to begin with, and number two, there's potential protective role of the female hormones. But we are able to extrapolate that data, those findings, based on the analysis of the data that they found. But of course, in the ideal world, what I would like to do is to be able to combine all this information. I don't think we need to invent or devise another measurement device. I think we have, what we have right now is appropriate. It's just a matter of combining them so that we're going to have a multimodal approach in analyzing the data. And hopefully the data that we will get there is not only something that will help measure treatment outcomes, but can help us predict. Wouldn't it be nice if someone had a stroke, for instance, they are admitted to our hospital? If we have all these data points, we will be able to personalize the rehabilitation approach that we are giving our patients. This is the reason why not everyone with a spinal injury, brain injury, or stroke recover in the same way, even if we give them the same intensive therapy program. Each person responds differently, but I'm hoping that in the near future, we can use these big numbers to help us with this. Couple last things for application in our field of study, using big data to help us better understand how we can prevent injuries in sports and at work. And this is a big one, healthy aging, community-based health maintenance. Having rehab done in institutions is very expensive. For those of you who've had physical therapy for a knee injury or shoulder injury, the copays, even if you have insurance, the copays are pretty expensive because you're not going to get better with one session. You have to go there anywhere from 5 to 10 sessions. But if we can do this at home, especially for those who are not yet injured, if we can help maintain the health of our aging population, I think we will be able to save a lot of money and a lot of trouble by being able to monitor activities that our patients are doing at home. So I can imagine one of these ladies past their middle age exercising vigorously, but they may not be exercising properly, or they may not be exercising enough, or they're not able to tolerate certain exercises because they're having shortness of breath or chest pain. So if there's a way in the future that home-based or community-based exercise and rehabilitation can be monitored by having sensors for the heart rate, sensors for breathing, sensors for oxygenation, sensors for joint movement, for strength, looking at compliance, I think that will help us improve the population health in general. So hopefully, one, rehabilitation professionals will be educated on the potential role of big numbers, of big data in what we do. And number two, hopefully we can collaborate, because you cannot rely on people in my field to do this. It will take a generation of PM&R professionals before we can change the way we think about how numbers can affect our work. So thank you very much.
Next up, we have Dr. Bj Fregley. He's a professor of mechanical engineering and bioengineering at Rice University.
So I have to thank Gerard for that introduction, because actually what we want to do is try to make patient-specific treatments for individuals with neurologic impairments a clinical reality. So the vision from my lab is we want to make data-driven, personalized treatments of movement impairments a clinical reality. So right now, if you think about how movement impairments treatments for movement impairments are designed, it's a very subjective process. If you talk to different clinicians, They may give you very different approaches for how they would treat a patient given the same information. And so what we want to do is take all the types of data that Daryl talked about and some additional data and be able to use that data to turn it into a model of the patient where we can then test different treatments on the patient's model, because we can't run a whole slew of treatments on an actual patient. It would be too costly and time consuming. In some cases, it would be unethical as well. So the mission for my lab is to use patient-specific computational models of the neuromusculoskeletal system to design optimal neuro rehab and surgical interventions for neurologic and orthopedic conditions. So we're also looking at certain orthopedic conditions as well. Right now, the applications that we're considering are stroke, spinal cord injury, Parkinson's disease, osteoarthritis, and we're also working in orthopedic cancer as well. And really, again, the big picture is let's perform virtual treatments on virtual patients. So we'll make a model of the patient, try out all the treatments on the model, and then ultimately we want to maximize actual real-life physical function of each patient. And again, because movement impairments, especially neurological conditions or orthopedic cancer, are very, very individualized, everyone is different, it's difficult to use cookie-cutter treatments in these situations. So what we're doing is we're taking a slew of different types of data. I don't think I would use the phrase big data, because big data for me is not the same thing as big data for all of you. I think what I would call big data, you guys would call little data. But big data for me would be we have like 500 trials of someone walking on a treadmill. So we collect all sorts of data. We could have static imaging data from CT or MR. We work with Dr. Scott Tashman at UT Health, who does dynamic imaging of bones using biplane X-ray. We have optical motion capture data, put reflective markers on the skin to measure movement, same thing they use for movies and video games. We actually have a project right now using inertial measurement units so that we can measure human movement out in the community. Patients can do it on their own. We can have muscle strength data, muscle electrical activity data from EMG sensors. We actually have some very unique data from people with instrumented knee replacements. So we have measured the contact forces inside their knees. That was work done by collaborators at Scripps Clinic in San Diego. And finally, we can have ground contact force data, how the feet interact with the ground. So during a typical movement data collection session, we can collect all those different types of data, but what in the world do you do with those? How does that help us come up with better treatments? And so what my lab does is we take all those different types of data and we combine them into a patient-specific model that models the neuro, the muscular, and the skeletal system of the patient. So we actually have patient-specific neural control models in our walking models that are different for individual patients. Someone who has a stroke will have a different model than someone who's healthy. And these models obey laws of physics, and they also follow principles of physiology. So unlike the more black box data science models, we've actually found for these applications, we want a model that has some physics in it. The reason being is that we have to extrapolate. We want to know if we do something to the patient and we're going to cut a bone or we're going to train something, that we're now moving into a domain where we have no data. So we have to have a way of being able to predict accurately when we move into domains with no data. So here's just an example of a walking prediction that we generated for an individual who had a stroke. And this is a prediction of how he walked at a faster speed, given how he walked at his self-selected speed. And if I show you an animation of what he actually did, it's pretty much dead nuts on. And so we're at the point now in the modeling world where we can predict how people will function under new conditions where we don't have data. So now the question is, how can we take these modeling approaches and use them to design treatments and actually show that the treatments would work? So of course, we won't apply the treatments initially. The clinician will do whatever he or she is going to do. We'll put what was done clinically into the models, see if the models predict the right thing. Once we have the modeling approaches to the point where they can predict the right outcome, then at that point, we hopefully want to start being able to try actual clinical treatments. So we're working with Gerard. We're trying to get some things started there. John Dewitt and I have actually predicted muscle loading during astronaut exercise in space on the ARED device on the ISS. And then Marci and I are looking at how can we take these sorts of models and put them into rehabilitation robots so we can predict the best way to use the robot and control it to maximize neuroplasticity and recovery.
Okay, our next speaker will be Dr. Marci O'Malley. She's the Stanley C. Moore Professor of Mechanical Engineering at Rice University.
Thanks again for the opportunity to be part of this panel and talk about something very near to me and the work in my lab. So I direct the Mechatronics and Haptic Interfaces lab at Rice, where we're really focused on human sensory motor augmentation and recovery. So I just want to give kind of an overview of the types of research efforts that are ongoing in my group. But all of the applications sort of center on this idea that physical interactions between humans and robots are information-rich exchanges that can be leveraged to enhance both human and robot performance. So there's you've already heard sort of a sampling of some of the research efforts in my lab focused on improving human performance, specifically how we can integrate robotic devices into a rehabilitation protocol following stroke or spinal cord injury and get recovery of movement coordination of the upper limb. And you see examples of that sort of on the bottom left-hand side of these slides. So we've designed our own devices. These devices are outfitted with sensors that can track arm movements. And then we can also incorporate other kinds of sensing like EMG or the EEG that Gerard referred to earlier to detect human intent. If we can understand the intent of the individual to move their limb, then the robot can provide that kind of assistance. And we're moving also into a space of more conforming and wearable robots in collaboration with Johnson Space Center and the Wearable Robotics Lab. We've got an upper limb exosuit that can assist these movements maybe out in the real world and outside of the clinic. Even our wearable devices include prosthetics as well. So we can think about improving human performance through advanced prosthetic devices that need to interact with the physical environment. So all of that is sort of ways that we can take information about human movement and control devices to support those movements and recovery. But also interesting is ways that you can take information and data about an interaction that a human is having with an environment and provide information back to the human that might improve the robot performance or might improve their overall performance in learning and training new tasks. So in the example of the prosthetics application, the individual is wearing a wearable haptic feedback device that conveys information about the state of the robotic device and its interaction with the environment to give them a sense of the hand posture, the opening and closing of the prosthetic limb. Otherwise, they have to visually attend to this. So we can outfit the prosthetic device with particular sensors and then map that to different cues that we convey back to the human user that they can then integrate that sensory feedback into their control system and improve the way that they're interfacing with the prosthesis. Similarly, in the surgical domain, we've been working with surgeons at Methodist in the realm of endovascular surgery and thinking about ways that they can get real-time performance feedback while they're training. Endovascular surgery is basically like trying to feed a string through a straw. You're inserting flexible guide wires and catheters into the vasculature, accessing through the femoral artery, and you're looking at a really fuzzy, two-dimensional X-ray image that's updated in real time. It's a really challenging motor control task, but we've shown that if you get additional data about how the tools are moving through the body, you can actually correlate the smoothness and efficiency of the tooltip movements to the surgeon's expertise. And you can do this at a very fine level, not just being able to tell me versus an expert surgeon, which is really drastically different, but being able to tell the difference between an expert surgeon, a fellow, or a resident. All specialists in endovascular procedures, but with differing degrees of expertise. So again, it's that access to data and information about how those surgical tools are moving, understanding how that correlates to surgical skill, and then mapping that to a useful cue that is fed back to the human operator so that they understand how to change their motor control strategies to improve their performance of the task. So I'm really excited about the discussion we're going to have today in the ways that data and access to different kinds of data can affect both human performance and maybe even robot performance.
And our final panel member is Michael Watts. He's a performance coach and sports scientist for Under Armour.
Thanks, Chris. I'll start by saying thank you to Jan and Chris and Rice for inviting me, and it's an absolute honour to be sat on a panel with people of this calibre. So the department I work for at Under Armour is the Human Performance and Science and Research team, so pretty apt to be here. It's split into 4 divisions. There is a biomechanics, there is behavioural science, there is advanced concept wear testing, then there is athlete performance. I head up our athlete performance division. Originally, I graduated in the UK did my master's in sport and exercise science there, and had just over 10 years in the English Premier League and with the English and Chinese FA as everything from a fitness coach to a sports scientist to a strength and conditioning coach to a performance director, and saw that evolution from data from heart rate monitors to the data we see today, which is absolutely everything. It's almost too much data. So I joined Under Armour 2 years ago. Now I have the privilege of working with people like Steph Curry, Bryce Harper, Anthony Joshua, US speed skating, and really diverse amount of sports. And you see sports that are very technology and data driven to sports that are still sort of set back maybe 60, 70 years. There we go. Got ya. So that's Aisha Pratt. She's one of our athletes. She'll head to 2020 Olympics, and she's been through the Performance Center, which is out in Portland, Oregon, a couple of times already, and she's due to come out again next month. So what my job really to do is deliver a performance service to these athletes. And really, this performance service needs to have some principles. It needs to be evidence-based. And we either do our own research, we have an expertise network, or we just read through the literature and make sure that whatever we are delivering to our athletes, that it has this evidence-based. We then try and build this system, and it's this holistic approach now to performance. When I first started, it was very much around training loads and how we could manipulate the training load and what dose we could give. Now it's holistic. Now it's nutrition, mindset, sleep, activity, training loads. It really is a lot of data coming in now versus what it was sort of 10 years ago. And then all the tools and technology plug in at the top. And this market is forever changing. Like I'm sure we're all very aware of how quickly this world changes. So we try and pick the tools and the technology that help plug into our system. And also, again, we want to make sure that they have some kind of evidence behind them and that they are evidence-based. One tool we use for movement, which I know probably some of the panel will be interested in, is a system called Fusionetics. And that was created by Dr. Mike Clark, who founded the NASM and then founded Fusionetics. And this tool helps us to assess an athlete's movement. So our real big buckets are movement, sleep, nutrition, then we sort of wrap that in mindset. So they're the 4 things that we really like to try and assess. And we just look at a joint-by-joint relationship with the athlete to see what's happening. We look at what's overactive, underactive, and then we can prescribe a bespoke self-care program or an elite sort of practitioner care program for that one athlete. Obviously, we monitor things like sleep. We're trying to monitor things like stress as well. So, and it's a combination. It's not just objective measures. There is still a lot of room in this world for subjective measures as well. Some of the work by Dr. Aaron Coots out in Australia, he looks at lots of subjective measures and sees like the place for them in this world. And then what we try and do with everything we do is always an assessment. So if you think about an athlete may come to us, or sometimes I travel and go to an athlete, it always starts with an assessment. And that might be movement, it might be sleep, it might be cognition. We have to assess the athlete in order to understand what their requirements and needs are. We then take that data and analyze it. We do some of that in-house. We rely on some of our partners to do that, or we hire people in to do that kind of thing. And then we give the solution. And this is always sort of a very bespoke level of solution to our athletes. We try and get away from just giving every athlete the same thing, because if you took sleep, for example, and you started going through the list of sleep hygiene things to tick on the box, like it's overwhelming for somebody to say, you need to do this, you need to do that, then you need to do that, consider this, consider that. Like if you collect some data to start off with, it might just be, hey, your room temperature is too hot, which is something we found with one of our athletes I think his room temperature was something like 85 degrees. And we were like, yeah, you probably need to turn down the thermostat a little bit. And then other things like he didn't have a problem with, like the light was pretty good. His sleep latency was pretty good. His bedtime and his wake time are pretty consistent. So we try not to overwhelm the athletes with insights or information. We try and collect data that's relevant. And that's all I've got for you.
Okay, so we have some time for questions. I'll start a couple while you all out in the audience think of things you'd like to ask. The heart of data science is always how do you get the information you want to utilize to make decisions. So why don't I get each of you to talk a little about the challenges of getting the information that's important to you and the type of information that you think is important.
So I'll start and I'll focus my answer on the NASA side of it. We found it's very difficult from a human performance perspective to get data that we want because quite honestly, we don't know what data we want. We have a small group. Bj said, you guys have big data. He thinks his big data is probably your small data. My big data is really your really, really small data. We have like 55 or 60 astronauts that we can study. And so the problem that we have is simply we take all this data, we put it together, but there's so much variability. One of the big questions we have that people want to answer is how much exercise does an astronaut really have to do to maintain their health? And that seems like a very simple question, but the problem is that, first of all, how do you quantify exercise? Is it time? Is it the amount of repetitions? Is it the distance they run? So you have these different ways that they exercise. Then you got this other problem. How do you quantify their health change? So the goal you would think is to go to space and stay healthy and not lose any bone and muscle. Well, here's the secret. I'll give you guys the secret of how to do that. Be out of shape when you go to space, because then you won't lose anything. The problem is our stronger people lose the most bone and lose the most muscle. They still come back stronger than our weaker people. So who would I rather have? I'd rather have the strong guy who loses a lot. So that's another conundrum that we have of we can't correlate performance with loss, because sometimes the performance that you're getting is actually what you're getting losses that you really want, even though it appears that you would say, I don't want any losses. So for us, we're still trying to figure out what that is, and it may be our sample size is just too small that we won't know, and we're going to rely on the groups here to help us answer some of those questions.
Dr. Francisco?
I knew it. I missed my calling. I should have been an astronaut. I would have been your perfect specimen there. I think in rehab, it's terrible for a rehab doctor to be saying this, but I think in rehab what we need is increased support and infrastructure. I don't want you to think that it's not happening in rehab right now. So the group in Galveston, Kenneth Ottenbacher's group, has a P2C grant on big data. He's had it for many years now, so he's cranking a lot of data. But one thing that I've realized since I got interested in this, largely after meeting Bj last year, when I started my own reading in this area, is that we're doing a lot in rehab right now that can be helped by this. But we will need more education to help us how those numbers can be harnessed so that we can put them to good use. Since the field of rehabilitation is so broad, we will be at a loss if no one will guide us in having a focus initially. Should we look at the normal first? How about the role in exercise for prevention of injuries, prevention of disease? Or should we start with the deceased population? If we choose a deceased population, should we start with stroke? Should it be diagnosis agnostic, rather just looking at impairment, meaning to say everyone with paralysis, regardless of the etiology? Or should we look at specific patient populations and in what age groups? We have not reached a point that we have even formulated the sensible questions that can be subjected to this testing. So I think we need to learn more about this so that we can discover how we may be able to use this in clinical practice.
Dr. Fregley?
Yeah, so from my perspective, the goal is to make models of individual patients. And so the data challenge that we have is, as Gerard said, it's very expensive to maintain a lab where you can collect all these different types of data. And so we like to work with clinical collaborators like Gerard and collaborators like Marci who are building hardware as individuals who are collecting data already. And then we can hopefully harness that data and use it for modeling purposes. But even when data are available, we have two main problems. One is that there are some types of data that just aren't available yet. So for example, we'd like to know what the forces are inside the human body when people move around. We could measure that in each of you, but we'd have to cut you open and put some sort of transducer on your muscle. And so most of you probably wouldn't like that, nor would the Human Subjects Review Board. So some data that we'd like internal to the body we can't get. And then second, to get the wealth of data that we need to make a model of any individual patient, it's very time intensive. It's not something where someone can come in and half an hour later you're all set to go. And so we need to find ways of being able to collect the types of data that we need. It's really a wide variety. Do it in an easy way in a short amount of time. Ideally, it would be great if patients could collect their own data at home, and then we could make the model of them even before they come into the clinic. And then when they come in to see the doctor could say, well, we've already analyzed you, and let's discuss what we think might be helpful for you.
So I think I see sort of two main challenges in the data collection that I do, and one is just the difficulty of access to the kind of data that we want, similar to what BJ was referring to. If I want motion data, there's sort of different costs associated with different ways of collecting motion data. I can get a nice Vicon motion capture system, and I can put markers all over your body, but now I'm constrained to an environment where putting markers all over your body is appropriate. I can't do that in a surgery suite. There's too much reflection. There's too much occlusion. There's too many people in there. So you have to think about sort of, while that would be the ideal way to collect motion data, I might have to compromise and settle for like a less lower resolution or lower specificity of data just to get some motion data. So there's always a trade-off in the applications that I work in with sort of what we want and what we have to settle for in terms of that data capture. And that could be motions, it could also be forces of interaction. The other is that often the systems that we use to collect data, for example, the robotic devices themselves, can actually change the way you move when you wear them. We look at exoskeletons to assist gait or to assist upper limb movements. The very dynamics of that robotic device are going to change the patterns and movements that you make. And we can do our best to design those devices to minimize the impact on your movement and the way sort of you coordinate your movements as you walk or as you move your limbs, but there's always some impact there, and so you have to kind of take that into effect too, that your measurement system may also be affecting the very thing you want to capture.
Pretty simple. Normally the challenge is the athlete themselves when you're trying to collect data. Usually we'll put an ask on an athlete where we might say, can you fill in this self-reported questionnaire on a daily basis? Or can you turn on this sleep monitor? And it's the habitual change in an athlete to start off with that is really, really challenging. And then also if you start to think of this 24/7 athlete versus when we used to just think they spend 2 hours at the training ground or just collect data on sort of training loads and RPEs, like that's a snapshot of these athletes' lives now. And there's quite an interesting study that Omega Wave did, and they look at DC potential, and they also look at heart rate variability, and they created this huge Bayesian network of data and really had a look at what was making a difference to team performance and injury, and sort of warm-ups, training loads were sort of fractional sort of percentage of what really made a difference. So collecting the data, knowing what to collect and when to collect it, because athletes often get a little bit annoyed when you keep collecting data on them on a daily basis and don't actually tell them anything. So that's a challenge. So it's knowing what to collect, when to collect it, on what cadence to collect it, and also giving the coach or the athlete an insight immediately. Like, it's no good telling them in a week's time, maybe you shouldn't have trained last Tuesday because you were a little bit overcooked. And these guys train every day, twice a day, 3 times a day. So you're having to turn the data around that quickly to give them an insight to maybe just change training loads a little bit or to back off a little bit that day. So yeah, it's not an easy space to work in.
Okay, so let me ask just show of hands. Do any of you feel like you're a data scientist today? Okay, good. I didn't think anybody, Little John, okay. So part of what I'd like to talk about, and I think a lot of us are working in industries where we're interested in applying these skill sets and these techniques and these tools in environments where the practitioners frequently weren't trained in that background. So let's talk some about the challenges of getting the right skills to the table and how you find the skills that help you solve the problems you want to solve.
I'll take that because I'm sure I'll have the shortest answer. I really think it's just a matter of, one, assuring the clinicians that we should not be intimidated by big numbers. I think that especially in my field, it's a very inexact field. I know it's a field in science, but it's inexact because we really cannot reduce patients to numbers. We're not, our specialty in rehabilitation does not rely on lab tests. Oh, there is a low blood count, do a blood transfusion. High white count, give an antibiotic. We don't do that. A lot of it really is what I would call a gestalt of the clinician in trying to figure out what will be the best rehabilitation approach. So numbers intimidate us. I think it will really help if we can find a way how we can collaborate, first in the area of education, second, not just providing information, but also making it apparent where big data already exists, because it does exist, but we just don't frame it that way. So I'm afraid that that's the reason why we have not exploited the data that we have right now in order to help us in our clinical decision making.
I'll follow up. I think I see challenges on two sides. One is I am a mechanical engineer, not a data scientist. So I tend to rely on data science methods that are fairly well proven. Right, so we might do a little machine learning. I didn't say that. But we rely on sort of published, well-grounded methods. So our innovations in what we do are really the application of techniques that are founded to new areas. And I think that's where the second challenge comes in, is in making sure that the work that you're doing is relevant to that target population. So in rehabilitation, one of the first things that Gerard and I collaborated on was, I was really excited about the potential for the sensors on the robotic device to give us real quantitative measures of movement impairment and how that might change over the course of therapy. Because in traditional therapy interventions with stroke, you assess pre-treatment and post-treatment, but your treatment might be over 2 months. So we were really interested in how these progressions might change. And the first step was to really put this in the language of the clinicians. So I could talk about movement smoothness and sub-movement analysis and all of these things that we were doing with the data. But when I started saying, well, this metric correlates to your Fugl-Meyer score, or this metric correlates to your Jebsen-Taylor hand function test score, then I was able to speak in a language that they understood, and we could start to find that common set of important outcomes in the research. Similarly, with the surgical skill, you have to make sure you understand the problem. And I think really the power of data in human performance is that it does give you so much access to information, but you have to sort of tie that to the outcomes that you're looking for.
Yeah. So I think it's important that data scientists help performance people really understand and figure out what's happening currently and what's happening in the future for athletes or just people in general. There's lots of what we call athlete management systems or data systems that already exist, and they do a pretty good job of visualizing data or humanizing the data, but nothing really exists at the moment that I've seen that can take data and it can go through some machine learning to be almost a little bit predictive, to say, if you follow this line, then this is going to happen. So it's a big area that's wide open, in my opinion, for data scientists to get together with performance people and start to really understand the athlete and really understand what it means when an athlete has a dose of training or misses some sleep or has poor nutrition. Like it's really exciting, and I think we're getting to a point very close now where somebody will crack that, and they'll probably make a lot of money doing it as well.
Yeah, so I think there are two challenges. One, Gerard kind of touched on it, is we do have to cross boundaries and find people who are willing to work together listen to each other, realize the engineers need to realize that the clinicians have something valuable to bring to the table, and the clinicians need to realize that the engineers have something valuable to bring to the table. Sometimes each side can feel like they should be the driver, and so there's not a real true collaboration. I had a phrase for this, I'm trying to remember, shared intellectual investment, I think was the phrase. You have to have problems where everyone involved has a shared intellectual investment in solving the problem. So I think that is an issue. The other issue is something I hinted at in my little introduction, is from my understanding of data science, it's typically you train models in a certain sphere of data, and you make predictions within that same sphere for new situations. And at least for clinical applications, we're typically going to want to predict for situations that are outside of the training sphere. And so personally, I would love to understand more what data science methods exist that extrapolate well, where if you give it some new situation that's outside of the training sphere, then you would be able to predict, here's how the athlete's going to perform, or here's how the patient is going to respond. So if anyone knows the answer to that question, I would love to hear what it is.
And I'll throw in something more from the sports side. When it comes to talking about how you use the data and speak with the practitioner, in this case it would be the coach or the athlete, I think we're in a dangerous time because there's lots and lots of opportunities to collect data, and people just collect data because they think, well, that team collected the data and they won, so we should probably collect this data also. And talking at it from a professional sports side or a college sports side, basically it comes down to three things. You want to win games, you want to keep your people from being injured, and you want to pay them the least amount of money possible to keep them on your payroll, right? You don't want to overpay them. You want to get rid of them when their value is higher than what you're paying for them so you can get more back. So it comes back, the guys who did the talk this morning from BP, I thought it was really good. They had 4 things for product selection: business value, tractability, stakeholder buy-in, and long-term technical capability development. I don't think it's any different in the human performance-wise. You have to talk to the people who you're working with. So it's not, well, this team collects data, so we should do it. It's this: the team should be saying, we have this problem. We're not doing this, or too many people are getting injured. How can we solve it? Let's talk to someone who can use data and help us. And then the collaboration begins. Because right now it's more like just throwing money at the problem of, well, we should do this because everyone else is doing it.
All right, probably a good time to see if there's any questions in the audience. One back there, there's a microphone coming.
Thank you. This question is mainly for Dr. Dewitt or Michael, but I think there's a little bit in there for everyone. And it's kind of the opposite of the first question that you posed. Wearables and athlete management systems are making their way down to the high school and club level right now. So by the time a young athlete finishes high school, he's using some wearables at school, some with his club, and some with his private gym that his parents pay for to get him that ride to the Division I. Then he goes to a Division I school, and now there are different wearables and a different AMS. Then his first contract out of college as a pro athlete is with Under Armour. After 3 years, he then takes his talents over to Nike. How is his data going to follow him all the way so that when this 27, 28-year-old gets to Nike, that coach isn't starting from square one and they have the history not just to what he just did when he was playing for the competitor Under Armour in the previous 3 years, but all the way back going to college and high school? I mean, we have this for health records, but I think we want to avoid that because the last thing the sports performance world needs is to put up with HIPAA. So what could there be in terms of a data science biological passport so that the coaches at the college or pro level get the value of everything that came before it?
That's a really good question because there is an argument that some of the data that are collected are health data. And so then you start into getting in, should these be in EMRs or not in EMRs? I don't know how to solve that because what you would need to do is have some sort of collaboration across everybody who creates some sort of sensor that creates some sort of data. Most of these are going to a cloud somewhere, or they're going right onto your device. But I think it's a very important point that's worth having more discussion on because this has implications not on what you're just talking about, but also on the long-term health of the person, because when they come to TIRR, it would be great if you could go back and look and see what this person did when they were in high school and college to inform things. So I don't think there's anything in place right now for that, and there probably should be something, but it's a tricky question.
Yeah, I'd agree with John. There's nothing to my knowledge that's in place. You do get sort of at the higher tier the biological passports within cycling, so they can understand if somebody's EPO count is off the scale versus what it was like last season, like what's going on there. So, but how do you track a youth athlete? And I work with kids who are as young as 6 years old, and some of those kids now play in the national team for England, and it's so much data has been lost on them that could provide so much insight into how to train a elite level soccer player, but you lose the data because they go from one coach to another coach or one club to another club, and nothing exists, and it's pretty sad that we do lose that data. Maybe there's a market there for somebody in the room to create something, but then again it comes down to, and John will tell you this, different clubs have a different philosophy about which tools they want to use. You take movement screening, for example. Some people use FMS, some people use Fusionetics, some people create their own. And it's not in the athlete's interest to do this to them. If you talk about continuity of care, that's not the athlete at the center. That's the coach dictating or leading what he feels should be the right way of doing it, rather than let's put the athlete at the center. Let's take them from 6 years old and take them through this process if they want to be a professional athlete, and really start to understand them and understand how to train them and understand how to recover them, versus just use them almost as this, I've heard them called like assets, and they just get moved around, and once they're burnt out you just buy another one. So it's a great question, and it doesn't exist, but I think it should do.
You know, I think there's a corollary on the medical side to you trying to quickly pass the idea that we've got the health records. I suspect there's more challenges in that field than we know. But also, how does the Privacy Act affect your ability to work on patients and utilize the big data results in the process of helping them? Any suggestions, Dr. Francisco, or any?
I'm having a headache thinking about this, because right now with the electronic medical records that we have right now, they don't talk to each other. So if we have this, and I certainly hope that we will have this in the future, it will add another level of complexity. How will this data be used? How will this data be protected? How will this be shared? It's a big problem, but I'm pretty sure that there will be a way to navigate that. And hopefully it's something that can be integrated in the existing electronic medical records.
And Marci and Bj, I am assuming in the world you live in, you have to get cleaned data before you can start analyzing it. Scrubbed of identifying features.
Yeah, so we have to be quite careful, especially in the collaborations with TIRR, that when we move and analyze data at Rice, that it's stripped of all personal health information. So we're down to just a subject ID number that's linked back, you know, in some file somewhere in a locked cabinet to the subject's name and diagnosis and their medical record. But we have to be really careful about what is shared, and we end up just referring to, you know, subject 1 through 10, and here's how they responded. Maybe we have a little bit of information about them that we'll publish, but it's all de-identified and not linked to any continuing care that they might be getting, because we're all in a research in the research domain.
Yeah, just to add to that, we don't have to do it that way. It's just the easiest way to do it. So technically, we could get patient identifiable information, but then we have to go through all sorts of other privacy hoops that would just, our research careers would be spent dealing with privacy hoops. So we just cut the losses there, save the time, and say and I do this in everything. I do exactly what Marci said. Just give me de-identified data. It's easy to get approved with the Human Subjects Board, because if someone else is collecting it and I'm just modeling it, there's really no risk to what I'm doing other than privacy. So if you take away the privacy factor, that makes it very easy to get approval for the human subjects part for us.
It might. Just one more thought on that. Well, it surprised me to know that John and I deal with the same thing in the astronaut community. Even though those are well-known subjects, we have to treat every piece of data we gather on every one of them as privately protected data. Mm-hmm. So even though astronauts are a very different, specialized community who would think would easily give us permission, our review processes don't allow us to do anything without de-identifying it as well. So, we have a question up here.
Yeah, my question's about identical twins. Obviously, in science, we like to do controlled experiments and in this realm, twins would help as control for a number of things. So I know NASA famously sent a twin into space, so I'd like to hear what we learned from that. Should we only allow twins to be astronauts in the future? And seriously, also to the rest, do you think we're properly using this potential for controls?
So I'll answer quickly from the NASA side. So the twin study that was done with the Kelly brothers, I wasn't involved with any of that, and all that data collection and analysis is ongoing. So there's still answers that are going to be given out later. There's not really anything now other than preliminary. But the bottom line is, now I'm speaking on behalf of myself, not on Chris or anybody else. I think when we figure out who's going to go on long duration missions, there's got to be some genetic aspect of that, because it would be silly if we can look in genetics and figure out something about long-term consequences of high radiation exposure or things like that and not using that as a selection. Having said that, we don't do that now. So I think maybe these sort of studies that have been done, not just at NASA, but elsewhere, could help to lead to this sort of thing.
Yeah, and I would not want to be on the review panel that limits our future astronaut selections just to twins. That would be a challenging discussion, I think.
Just from the perspective that we've had with studies, I haven't had any identical twins in any studies, except the things I do on my own fraternal twin children, which is mostly social experiments. I'll clarify. They're 11. It's a journey every day. But I will say, I think what's really challenging, especially in the neurological impairment domain, is just how much heterogeneity there is. I can have two subjects, in a study with Gerard, who are roughly the same age, roughly the same time since spinal cord injury, injuries both at the cervical 4-5 level, who are drastically different in terms of their recovery and motor coordination. There's a lot of work being done in stroke rehab and trying to assess the potential for recovery. Quite a bit of potential recovery, just depends on how severe the injury is at onset. And I think that's one of the challenges when you come to human performance is, wouldn't it be great if we could identify which surgical residents were going to be good surgeons down the road and only train them? We can't really, we're sort of more at the assessment end. So it's a challenge. It's certainly a challenge, the variability across people.
There's a lot of interest in rehabilitation. Our colleagues at the University of Pittsburgh coined the term rehabiliomics, which is rehabilitation using the principles of genomics, hoping that we might be able to predict outcomes in response to therapies. Because this is not only for the sake of the patient, there's a lot of health economic implications as well. If we know from the start that someone will have a tremendous functional outcome after a stroke, then we should invest more in that person as opposed to someone who is not likely to recover independence. So we're very much interested in that, and hopefully this is something that we can incorporate in our practices.
So this actually kind of trickles us into a discussion about the ethics of gathering data and applying it long term, right? Again, I think, Michael and John, you work in environments where your subjects are essentially voluntary and basically willing to do whatever it takes because of the performance characteristics they wish to achieve. But I don't know that you can apply that across the broader community. There probably are some ethical discussions about what you can provide to them, what they can bring to the table, and what you can work with. How do you consider that in the process of moving forward with the science you want to study?
Yeah, it's the question I always get asked when you start working with a new athlete is, where's my data going to go? Or who gets to see the data? And when you take, so Anthony Joshua, he's the world heavyweight boxing champion. He holds 4 belts, and we engaged with him a few weeks ago, and it's pretty intimidating when there's a 250-pound guy who's 6'6" asking where his data's going to go. Your usual response is anywhere you like. But yeah, and you think that you are privileged to be in this position of you are seeing this guy's data, you are collecting it on a daily basis, and the insight you're getting really is building up to this guy being in a $100 million fight sort of next April, probably against an American boxer over here, and I think that'll be in London. And you get to see some amazing insights, and then you see a little bit come out maybe in the press, and you understand what's going on. And in the life of this athlete as he builds up into a major sporting event, and you see the stress that occurs, his lack of sleep, his injuries that start to pile up. So it's really sensitive stuff, and to keep that data and sit on that data and then give him some insights and feedback is a real privilege to be in that position. So it's just a case of you have to be very secure in how you hold your data. You have to see that as a privilege. You can't have too many people who have eyes on that, because there's obviously a trust thing. If somebody leaks something like, oh, I didn't realize that guy had a bad back or whatever, and it gets out, then all of a sudden the athlete or the team know where that leak probably came from. So it's a real challenge to really say who gets access to the data, what do you do with the data, and how do you ultimately protect that athlete. And again, it comes back to putting that athlete at the center and making sure that you protect him and his rights to share his data with you.
So can I shift to the surgical domain, where we've had some interesting discussions? So surgical expertise is often characterized by caseload, which is just how many procedures you've done, which might not necessarily correlate with skill. And so with the dawn of some robotic platforms, there's this tendency to take an experienced surgeon who's done a lot of manual procedures. They go to a weekend boot camp, they get a certificate, and now they're certified to do robotic surgery. And they start practicing using a Da Vinci robot or pick your surgical robot. There's only a few. But how do we know that they're actually now skilled in using the robot? And so I think it's, there's the sense here that it's really important that you quantify these things and make sure the assessments are objective, because now you're talking about potential patient outcomes from procedures. Similarly, if you think about the investment made by individuals in going to medical school and through residency, if you had a way to understand which people are best suited to certain specialties because of their coordination and skill, wouldn't you want to invest your training in those who are going to be the most effective surgeons down the road? Certainly the military is interested in this for their pilots and astronauts.
And we've had similar discussions about astronauts,
Yeah.
Trying to align them where their skills tell us they're most effective. I think you have time for one more question.
Yeah.
Don?
Okay, I'm going to actually use the opportunity to ask one question, because I have one question that actually I think cut across everybody. So you may want to ask another. So I'm a sort of a habitual runner. I'm sure there's many other in the room. I sort of asked this on a phone call earlier with the group panel. And 3D manufacturing is here. A lot of embedded stretch sensors, as we saw in the flexible wearable. I want to go into Fleet Feet, sorry for advertising, and I want to buy my shoes by my feet being scanned. Digitally scanned, printed, delivered to my door in a few days, fully embedded with sensors. Next time I come in, I want to bring my iPhone or my Android, and I want to bring all the data that it's collected while I've been out running for the last months, year, to buy an even better shoe that is fitted for my gait and my running style to minimize, increase my performance, injury prevention, and maybe I'm in a rehab store. Seems like this actually cut across technologies that all of you would benefit from. Will that happen? Are we close to having that happen? I don't know. Maybe start with Under Armour, because they're in sports gear business.
So yes, it will happen, and I think it'll happen quicker than we potentially think. Currently, we do have smart shoes that have an accelerometer in them, and they can measure basic things like contact time, flight time, that type of thing. So it can measure your cadence, your distance, pace. There used to be a neuromuscular fatigue test in there as well, but they took it out because nobody used it. But yeah, and it's coming. And then in terms of people actually going into retail and doing a foot scan, the technology obviously exists already. I think that will happen, but I don't think it will just be this point of vision where it's just what's going on with my shoe. So if your foot flattens, for example, yeah, they might build up the arch a little bit, but I think they'll want to actually say, well, let's fix that problem. Let's understand sort of what's overactive, underactive. Let's understand how to train you, and let's also understand what clothes you need to buy or what equipment you need to buy. So then that whole package is wrapped around you in this little ecosystem of, I know my body, I know my metrics, I know what I need to buy, I know how I need to train, and then I can come back in and be assessed holistically versus just looking at my foot.
And would some of those same thoughts apply in the rehabilitation world, customized rehabilitation tools?
Yeah, and I'm optimistic that this will happen soon because it's in its infancy stage. From what I know, that the things that you've mentioned, we have all of them already. They're just not put together. So we now have accelerometers. We have devices that can measure how many times a limb was used to perform a particular activity. Some of the existing commercially available wearable exoskeletons can collect EMG data if set up that way. 3D printing of exoskeletons is being explored. So I think it will be very beneficial. Again, it's cost. The reason why many of these wonderful devices have not been used clinically is that they're so expensive that in order for a patient to access them, they have to go to a clinic. So hopefully 3D printing, for instance, may decrease the price of exoskeletons, so make it more accessible. Perhaps it's even a device, something that can be used over a longer period of time. So for example, a child with cerebral palsy who does well with an exoskeleton, as that child grows, rather than throwing that exoskeleton and getting a new one, perhaps they can just refabricate using 3D technology parts of the exoskeleton, and it's something that can be used over a longer period of time.
And there's one more thing I'd like to add. And Jan, this is, I think, the one thing that the barrier to what you're talking about right now is being able to create the sensors so it doesn't alter the way the person actually performs the activity. And, you know, the foot sensor, for instance, when you're running, you're going to get ground reaction forces that are 2 or 3 times your body weight at just on a regular stance. Go for a 5-mile run and you're going to, you know, I don't know how many footfalls you're going to take. Sensors just break down. So I think the problem is that it's development of the sensors. It's not only cost, but ones that don't break down and don't hinder you, because I think people they'll wear what they think is going to help them. You know, you'll tolerate a chest strap, you'll tolerate maybe a wristband. If you have to put 16 IMUs all over your body before you go on every run, just so you can figure out if your shoes are good, you're going to say, I don't want to do that. So the sensors have to, the technology and the longevity of the sensors has to become a little bit better also.
And if I may add, hopefully the data will be analyzable easily. Because we don't want to add another obstacle, which is just the time factor. And if it's so tedious, people may not use it.
Just to piggyback off John there as well, I actually think that wearable sensors will probably be removed from the consumer in the next maybe 5 years or so, because we call them single-use wearables like a heart rate monitor or an accelerometer, whatever it might be. We're finding that the consumer actually wants to be untethered and they want to be free of technology. They just want this automated process of, I'll put something on, I'll go and do what I want to do, and then I'll get my insight. They don't want to start wearing stuff because that's just too much friction to put something on. So I think we'll find that wearables are either embedded in apparel, footwear, or potentially even the skin, whether that be a 24/7 wearable that monitors everything, or that be a tattoo. Like that's pretty close to coming to the consumer as well.
All right, do we have time for the last question up front, young lady?
I have that one question. Yeah. Last question.
So I have a question that's somewhat related to the last few questions, and so I'm not sure about the wearables losing popularity, at least amongst the quantified self movement. So that's a growing movement of people who are biohackers and quantify selfers and people who would voluntarily and excitedly put 16 sensors on their body just to get their data. But with people who want to collect their data, the question comes, who owns the data? Do you guys own the data that you collect on the person? Can they have their own data? Is it theirs? Is it yours? And if you do give it to them, can they then take it somewhere else? That seems to maybe solve some of the problems of, hey, I can't, you know, it was collected here and then now that's lost. Can we start giving people their own data and let them kind of handle any privacy leaks and problems because now it's in their hands? Or I guess my question is, who owns the data and can people have their data?
Great question. I think now, since we're using this primarily in research, we own the data. because it's research data. But if this will be incorporated in clinical practice and becomes part of the medical record, then it becomes the data of the institution, the hospital or the clinic, but the patient, of course, has access to it and can control how the data will be shared.
I suspect the answer to that's different in every environment.
Yeah, I was going to say for any federally funded grant, you have to have data sharing plans now for NSF and NIH grants, and often that's sharing de-identified data, but at least the data is out there. If other groups want to analyze it, you have to have a plan for dissemination of that.
Yeah, I think we would own the data. We've got a digital community, about 260, maybe 270 million users. That's across a nutrition app called MyFitnessPal. There's Map My Run, there's Map My Ride, there's Endomondo. So I'm pretty sure when you sign up to one of those, you probably sign a waiver to say that we own the data. And then what we do with that is obviously down to Under Armour in terms of understanding habits and understanding what users want to do. And then, yeah, to your point, like these biohackers that are wearing everything, I think they're in a minority. They do exist, they're in a minority, but I'll give you sort of one stat. If you took our Map My Run users, there's less than 5% that use a heart rate monitor. So it shows you sort of like the masses are moving away, but I do agree with you. There's like a real hardcore that are biohacking and collecting data 24/7. So yeah, it's an interesting space.
I think just to follow up on your point of moving away from wearables, I think it's not necessarily moving away, but just that their form is going to change. I think the tattoos, the embedding, sensing, and clothing, that's going to be, so it's essentially, it's still wearable, but it's not this extra step that you have to do. It's going to be just part of our everyday activity monitoring.
So thank you to the panel and thank you for the audience. Excellent questions.